Good afternoon, and many thanks to the conference organizers for the opportunity to speak with you today. My name is Mark Siedner. I'm an infectious disease clinician at Massachusetts General Hospital and Harvard Medical School. And I'm going to be speaking to you today about our work on HIV and aging in sub-Saharan Africa, with an overarching question of whether the song remains the same. Does HIV induce aging in similar patterns in sub-Saharan Africa as it does in the United States and Europe? These are my funders. I have no conflicts of interest to report. Brief summary of what we'll speak about in the next 20 minutes. Well, first I'll talk a little bit about HIV as a chronic inflammatory condition and the impact of that inflammation on non-communicable diseases, cardiovascular disease, and aging in the United States and Europe. Then we'll shift gears to talk about similar paradigms in sub-Saharan Africa, first looking at how HIV induces inflammation in that part of the world, and then talking about relationships between HIV, non-communicable diseases, and aging phenotypes, with the conclusion about some of the key remaining questions for the field in this area and some research priorities. Soon after antiretroviral therapy became available in the United States in the mid-90s, it became clear that life expectancy was going to increase rapidly for people living with HIV. On this graph, each of these circles represents life expectancies after the age of 20, and the dark circles are people with HIV, where the white circles are people living without HIV, and you can see there was an incredible gap before antiretroviral therapy was widely available in the United States, but that gap quickly closed and has nearly closed in the 20 years since. As people with HIV age, it's quite clear that AIDS is no longer the leading cause of death among this population, and it became immediately evident that there were other issues of people living with HIV aside from HIV infection, opportunistic infections itself. I'm going to try to summarize about 30 years of extremely complex and extremely high quality science in about the next 5 or 10 slides. One of the first phenomenon that became evident is that people living with HIV almost immediately lose their gut immune system. And unlike the peripheral CD4 counts, which do recur once people start antiretroviral therapy, people with HIV actually do not repopulate the majority of their gut immune system after antiretroviral therapy is initiated. The loss of gut immunity leads to a number of things, but one of the things that it seems to induce is translocation of bacteria across the gut into the bloodstream. This is a graph showing levels of lipopolysaccharide, which is a marker of bacterial cell walls, comparing people without HIV, those in acute and early infection, those with chronic treated infection, and those with advanced disease. And you can see that even chronic treated infections associated with higher levels of bacterial load in the blood than people who are uninfected or acute early disease. Partially due to that translocation, but also partially due to chronic immune activation from HIV itself and co-infections like cytomegalovirus, it's now quite clear that people living with HIV continue to have elevated markers of immune activation. Both soluble CD163 and soluble CD114, are markers of macrophage activation, which remain elevated in people with HIV compared to HIV uninfected people, even after antiretroviral therapy. This is also true of cellular markers of aging. This is a classic study, now 25 years old, amazingly, showing that people with HIV have shorter telomeres than people without HIV. Telomeres being the ends of our chromosomes and markers of actually genetic aging. Similarly, this is a study comparing what's called immune senescence, or basically the ability of our immune cells to continue to repopulate. Both T-cell markers CD28 and CD57 are markers of immune senescence. And this is some data amongst others showing that people living with HIV tend to have higher markers of immune senescence, or basically a tiring out of their immune system, even after antiretroviral therapy. Priscilla Hsu at UCSF and many others began to look to see how these markers of immune activation and immune aging were affecting markers of cardiovascular disease and cardiovascular disease risk. And this is one of the first studies in that area showing that people with HIV, which are notated by these dark circles here, compared to HIV uninfected people, have higher levels of immune-specific response to things like CMV, and that those are actually associated strongly with end-stage disease markers, in this case, carotid intermediate thickness, which is a marker of atherosclerosis or cardiovascular disease health. Although it was initially considered that potentially part of the increased risk of things like cardiovascular disease in people with HIV was due to traditional risk factors like smoking, hypertension, diabetes, it's since been quite clear that that's not the entire picture. This is a study in France looking at rates of acute myocardial infarction in people with HIV as determined by these orange boxes, and people without HIV, which are these gray crosses here, and that After adjustment for risk factors, cardiovascular disease risk factors, people with HIV continue to have higher rates of myocardial infarction than HIV uninfected comparators. As people with HIV continued to age, it became also increasingly important to understand how aging itself would differ by HIV infection. And this is one of the first studies in that area by Meredith Green and her group at UCSF, which looked to see the odds of physical performance, in this case, the short physical performance battery, how that compared between HIV uninfected and HIV infected people. And what she showed is actually across the board in this cohort, this I believe is the alive cohort, people with HIV had higher odds of decreased physical function than HIV uninfected comparators. The link between things like functional impairment and inflammation has also been drawn. This is data from Christine Erlinson group at University of Colorado, showing those with higher function having lower markers of immune activation like soluble CD14 and IL-6, which we discussed earlier, compared to compared to people with higher function who had lower markers of these immune activation markers. Increasingly, it's clear that these inflammatory phenotypes do not just affect things like biomedical disease. And there's been a number of studies now from the WISE cohort and others showing that social functioning, things like social isolation and stigma, are also affected by HIV and also associated with things like biomedical aging, cellular aging, and the immune phenotype. Putting all this data together, a paradigm has emerged. This is work, a review paper by Amy Justice, which I think really nicely describes this entire paradigm. That the combination of HIV infection, other infections, other social factors, all lead to markers of immune activation, inflammation in HIV infected people. These features combine to cause an incremental reduction in immune function and organ system function, all leading to things like functional decline, organ system failure, hospitalization, medical needs, and eventually to death. I think the question that we've had is whether this same paradigm, whether these same patterns of HIV leading to immune activation, leading to immune dysfunction, leading to cardiovascular disease and functional declines are seen in sub-Saharan Africa the same way they're seen in the United States and Europe. This is an important question for many reasons, not the least of which is that about 70% of the world's population of people living with HIV are in sub-Saharan Africa. Importantly, and similar to the United States, soon after antiretroviral therapy became available in sub-Saharan Africa, life expectancy increased dramatically, and not just for people living with HIV, but for the entire population because the prevalence of HIV is so much higher in that part of the world. This is data from Till Barninghausen and his group from rural KwaZulu-Natal. Unfortunately, it took another 10 years approximately for antiretroviral therapy to become available in South Africa in the public sector. But once it did in 2004, life expectancy in the general population increased by over a year for every calendar year that passed over the next 10 years. When this is broken down and divided by HIV serostatus, almost its entire gain was amongst people living with HIV. But since they are such a large proportion of the population, it had entire life expectancy benefits in the population at large. Soon after these paradigms emerged, we began to try to study this in sub-Saharan Africa, and this is work from some collaborators in Uganda, where we've been following a cohort of people over 50 years old and trying to understand how HIV impacts things like inflammation and cardiovascular disease risk. Similar to the United States and Europe, we found that markers of inflammation are higher in people with HIV. On the left, this is soluble CD14, again, a marker of macrophage activation, and this is high sensitivity CRP on the right. You can see both amongst men and amongst women, people with HIV have higher markers of inflammation. We also found in Uganda and South Africa that biomarkers of inflammation tend to be higher in women than men across the board, both for people living with and without HIV. Won't dive into that in this talk, but happy to discuss that more later if people are interested. This is some data repeating the telomere studies in people living with HIV in South Africa. This is a study from Cape Town. Similar to the United States, showing that telomere length is lower in people living with HIV than HIV uninfected comparators. But I will say, soon after we started noticing that markers of immune activation were increased, some of the data started to diverge between South Africa, Uganda, and the United States. This is data back from the United States now looking at traditional risk factors, which we mentioned earlier are higher in people living with HIV than HIV uninfected comparators in the United States. So this is prevalence of hypertension, diabetes, dyslipidemia, current smoking, all higher prevalences of people living with HIV than HIV uninfected comparators in the United States. We repeated some of this work in Uganda. This graph's actually reversed. This is the American Health Association ideal levels of cardiovascular health scale. So higher levels on this graph show improved health. What we found in Uganda is that people living with HIV tend to have better rates of smoking control, either cessation of smoking or not being current smoking, better healthy diets, higher prevalence of blood pressure control, and higher prevalence of blood glucose control. Ghaziano and his group has done similar work in South Africa as part of this incredibly large and healthy study in rural South Africa, showing something similar, that HIV, people living with HIV tend to have higher rates of comorbidities defined by things like hypertension, diabetes, hyperlipidemia than HIV uninfected comparators. We've also begun to look at surrogate markers of cardiovascular disease. This is the cohort from Uganda again. We recently presented this data at CROI. And actually, much to our surprise, we found that people with HIV, which are the blue lines and blue dots on this graph, tend to have similar rates, similar thickness of the carotid media, or a measure of atherosclerosis, than HIV uninfected people, both at enrollment into the cohort and over time. This is a cohort which is matched by age and sex, so those are not confounders in this study. In the United States, this is work by Felicia Chow and others at UCSF. Fairly well established at this point that people living with HIV have a higher incidence of stroke. We've recently undertaken some studies looking at this in South Africa. This is incidence of fatal stroke in a community-based cohort in rural KwaZulu-Natal. And what did we find? We found that people living with HIV who had not yet started ART, which is in this middle column, had similar rates of fatal stroke as people that are HIV negative. By contrast, HIV infected people who had been on ART for at least 6 months had significantly lower rates of fatal stroke than either of these two comparator groups. What about markers of aging? This is data from the Halsey study again, Colin Payne and others, showing across the board, irrespective of age, that people living with HIV tend to have similar rates of disability, in this case as measured by having requiring assistance with at least one activity of daily living, comparing people with and without HIV. Similar data from a group in Cape Town comparing frailty measures, really no difference between people living with and without HIV. And this is some recent data which is put out from our rural cohort in South Africa of about 700 people comparing the frailty phenotype, and actually, again, finding no difference, if anything, higher rates of frailty phenotypes in HIV uninfected versus age and sex matched HIV infected comparators. People have started to compare cohorts across countries and continents, and this is some early data, again, by Colin Payne. I'll just have you focus on two of these lines. I'm sorry this graph came out slightly blurry, but this dark purple line here, this is a US cohort, and this orange line is a South Africa cohort. This is the Halsey cohort from South Africa. What you can see in this case is this walk speed, a gait speed, that there's actually a pretty strong difference between the US cohort and the South Africa cohort in 65-year-olds in both men and women, but the gap closes over time. And particularly interesting is that there doesn't seem to be much of a drop-off in gait speed in men or women in South Africa, whereas there is a notable decline in men and women in the United States. One last study from Halsey. Again, this is from rural South Africa, part of the Halsey cohort. This is about 4,500 people who completed neurocognitive testing as part of that study, a very large, really elegant study, looking at cognitive function both by age and serostatus. And again, remarkably, what they found in the Halsey cohort is overall, people living with HIV had slightly higher levels of cognitive scores than HIV uninfected comparators after adjustment for age. What about quality of life, which I think at the end of the day is where we want to get with most of this work. So this is a complicated slide, but let me walk you through it. This is data that we're just now submitting from a population cohort of about 18,000 people in South Africa who completed a large battery of cardiovascular and infectious disease medical testing. What did we find? Well, this is data here looking at quality of life as measured by the EuroQol EQ5D scale. We're particularly interested in this, trying to understand which features of multimorbidity have the greatest deficits on quality of life. And what did we find here? In the red, you can see that some of these non-communicable diseases like stroke, heart attack, and hypertension were all associated with decreased overall health-related quality of life, but also decreases on most of the subscales. By contrast, a bit to our surprise, people living with HIV after adjustment for age and sex had higher scores in terms of overall quality of life in each of the subscales across the board than people without HIV. Why might this be true? Well, this is also data from that same cohort study. So again, this is 18,000 people. And each of these are graphs of the prevalence of some of these major diseases that we looked at. So HIV, tuberculosis, elevated blood glucose, elevated blood pressure. And these are ages based essentially from the age of 15, which was the recruitment age of the cohort, up to the age of about 100. Each of these graphs show the prevalence of disease as determined by the green and the red bar together, where the light green here is controlled disease and the red bars here or active disease or uncontrolled disease. In the case of HIV, that means having a detectable viral load. In the case of elevated blood glucose, that means having an A1C greater than 7. And in case of elevated blood pressure, that's having a blood pressure greater than 140/90. And one thing I think is quite striking here is that especially for the young people, HIV is incredibly prevalent in this part of South Africa with prevalence rates up to 40 or 50%. But in contrast to the NCDs, people with HIV by and large have controlled disease. We found over 80% of people in this cohort had suppressed viral load. And this contrasts pretty strongly with the prevalence of controlled disease, both for diabetes and for high blood pressure. So how do we put all this together? First, like the United States, we're finding that biomarkers of immune activation, of inflammation, markers of cellular aging are all increased in people living with HIV compared to HIV uninfected comparators in the population in sub-Saharan Africa. But by contrast, and importantly, chronic disease risk factors in conditions, whether they be hypertension, diabetes, or markers of aging, appear relatively improved, if not similar, among people living with HIV in sub-Saharan Africa. This includes syndromic measures of things like frailty and physical functioning, and things like self-reported health and quality of life. So where does this leave us? I think we have lots of questions to answer. The first, I think, is we really need to understand, is HIV associated with accentuated or accelerated aging like it is in the United States? One theory that we have is this idea of a primary care paradox, which is basically stated that in sub-Saharan Africa, HIV has really become a form of primary care, such that people living with HIV who are diagnosed see nurses, they see doctors, they see pharmacists, they often see counselors, maybe once every month or two. And they're some of the only people in the region, in terms of adults at least, who do have routine primary care, whereas most of the other healthcare delivery services are done for acute care for people that are ill. Another potential hypothesis is the idea of a survival bias. So because HIV services were relatively poor or non-existent in sub-Saharan Africa for an additional 10 or 20 years, people living with HIV may actually, and having survived that, may be a hardier group of the population than HIV uninfected people. And so the people in these older age cohorts could be a select few who made it through. I think either of these or maybe both of these are possible, but they're really important features to think about when we try to understand how HIV impacts aging in the region. It's really important, I think this data is teaching us that we can't just use US and European data to make inferences about life, well-being, health in sub-Saharan Africa. There are important differences in terms of healthcare delivery, genetics, local exposures like cook stoves and pollution, and of course, access to care, which are extremely different in the sub-Saharan African region. As we start to sort this out, I think it's really important for us to think about how interventions need to be different, because it seems like the paradigms are different. Can the HIV care platform in sub-Saharan Africa be leveraged, because it seems to be stronger than most of the other healthcare systems in the region, to improve health and well-being for older people in the region? We've begun to study this, and we've developed this paradigm of trying to think about aging with HIV in sub-Saharan Africa, where we think social factors and certainly things like familial HIV deaths and community support are going to have an outsized force in determining health and quality of life for people with HIV, in addition to the standard biomedical factors and the HIV disease factors, which we talked about, like immune activation and cellular aging. All of these things, of course, are going to contribute to various forms of functioning and ultimately to quality of life. And we've just begun a study this year to try to understand this. It's a multi-year cohort of about 600 people in Uganda. We're in the first year of a 4-year longitudinal study, and we're focusing on these biomedical features, but really want to take a deeper dive into things like frailty, physical functioning, neurocognition as part of this. We've enrolled about 300 of our first 600 participants here in year one, and hoping to have some data to report not only after year one, but of course over time, as we can look at trends and really differentiate some of the prior work, which is largely cross-sectional, from longitudinal observation. Both the Ugandax study and many of the other pieces of work I've shared today are extremely large collaboration. This is a small group of many of the co-investigators I'd like to thank. And I'll stop here. Thank you for your time and take any questions.